Hello, my name is Selena DiBiasio, and our project is Point of Care Ultrasound in Undergraduate Medical Education, a scoping review of assessment methods. I'd like to thank the co-authors, Dr. Sheffrin, Dr. Pajot, Dr. Wu, and Dr. Chung for all of their support and contributions throughout the project. Over the last 2 decades, Point of Care Ultrasound, also known as POCUS, has rapidly expanded in undergraduate medical education. However, a curriculum's success is not defined by its growth, but by its effectiveness. The effectiveness of POCUS curricula is measured by assessment of learning, with clinical competence being essential for high-quality patient care. However, there's very little literature dedicated to reporting and characterizing POCUS assessment methods, and no consensus on which assessment methods are the most effective to evaluate skill or competency. Miller's Pyramid for Clinical Assessment provides a well-established framework for assessment of clinical competence by linking learning outcomes with expectations of learners' abilities at 4 different levels. Providing an overview of the current assessment methods used in POCUS undergraduate medical education and how they fit into Miller's framework will help guide medical educators when selecting effective assessment tools for their curriculum. In response, our scoping review aims to report, characterize, and categorize the current methods of assessments for skills, performance, and competence in POCUS undergraduate medical education reported in the literature. Our protocol was developed using the preferred reporting items for systematic reviews and meta-analysis, or PRISMA, extension for scoping reviews. No research ethics board review was required since there was no patient data. The data charting form was developed using categories including participant demographics, study specifications, assessment methods, and competency specifications. Each category was then subdivided further. We first conducted a librarian assistant search of Medline from inception through August 4, 2020. Inclusion criteria included all English language undergraduate medical education publications in which POCUS-related knowledge, skills, or behavior were assessed in isolation from non-POCUS-related items. Any duplicate articles were removed. A single reviewer screened all abstracts for inclusion, and a second reviewer independently screened a random sample of 10% of all abstracts for inclusion. Cohen's kappa was used to determine the agreement between the 2 reviewers. We used Miller's Pyramid of Assessment as a framework to categorize assessment tools, and we combined levels 1, knows, and level 2, knows how, since most papers didn't define their written or multiple choice examinations. The search yielded 558 titles from approximately 25 countries. 166 articles met inclusion criteria, and data was extracted to a standardized data collection form. The Cohen's kappa for this scoping review was 0.953. 51% of the articles assessed pre-clerkship students. 19 articles used only surveys for assessment and therefore did not assess the skills learned as defined by Miller's Pyramid. 73 assessment methods used exams, mostly multiple choice, to assess students' POCUS knowledge of their learned skills, which met criteria for levels 1 and 2 of Miller's Pyramid. Level 3 was the most popular level, with practical examinations like OSCEs being used for learners to demonstrate their learned skill. At the top of the pyramid, 4 assessment methods assessed for clinical performance as defined by Miller. Notably, about 22% of research articles included assessment methods at multiple levels of Miller's Pyramid. The majority of articles included used an objective means of skills assessment. Only about 4 assessment methods met criteria for the highest level of Miller's Pyramid does. Of these 4 articles, the most common sub-competency to be assessed was technical skills of acquiring clinical ultrasound images, with only 1 article assessing the student's integration of the skill into medical decision-making and daily practice. We therefore need tools for higher level of skill integration. The idea of competency-based medical education has grown, and the term competency has been used more frequently. We found that there was a disconnect in literature of what people reported as competency versus its definition. The limitations of our search was that we only used Medline in our scoping review due to the large number of articles we found. A variety of assessment methods are currently used in POCUS undergraduate medical education. Most of these assessment methods fell under level 3 of Miller's pyramid shows how. A small number of studies reached level 4 of Miller's pyramid does, which assessed workplace performance. We advocate that there should be a greater number of assessments in the workplace, which fit with competency-based assessment in day-to-day practice. The results from this study have the potential to guide medical schools, medical educators, and program directors to choose assessment tools for their POCUS curricula that emphasize clinical competency and thereby will help provide high quality and safe patient care. The following are our references used for this project. Thank you for your time, and if you have any questions, please email.
Alrighty. So my name is Michael Pyor. I'm one of the emergency medicine PGY1s at Washington University, St. Louis. And I'll be giving a presentation on nerve blocks for reduction of opioid use in elderly patients with hip fractures. I have no financial disclosures, a brief outline of my presentation. So I'll first talk about opioid morbidity and mortality in the elderly. I'll next talk about nerve blocks and their effect on opioid use. I'll go into the data that we so far have for our project, and then detail future directions at our institution. So starting out, morbidity and mortality of opioid use in the elderly. So between 2005 and 2014, there was a 64% increase in opioid-related hospitalizations. In the elderly, prescription of opioids, you have to consider multiple things that you wouldn't consider in younger individuals. So starting off, metabolism is different in elderly patients. The metabolites of certain opioids, such as codeine, hydromorphone, oxycodone, are a result of hepatic metabolism, and because of the age-related changes, they'll affect patients in different ways. Adverse effects of opioids are numerous. There's the risk of long-term dependence. There's risk of constipation and ileus, increased risk of infections such as pneumonia, and certain opioids like methadone have dangerous side effects such as QT prolongation and resulting arrhythmias. Furthermore, dementia is highly prevalent among elderly patients, and that confounds our ability to gauge whether or not we're providing adequate analgesia and balancing the fine line between providing adequate analgesia or over sedating patients with opioids. Now, there is very limited data currently on prospective randomized controlled trials of femoral nerve blocks versus opioid use in the emergency department. Here are two small studies that looked at femoral nerve blocks in one group and opioid use in another. Without going into too much detail, both of these studies found that utilization of femoral nerve blocks dramatically decreased the amount of opioids that were used without major adverse effects of the femoral nerve block. So our data so far, we have completed a retrospective cohort study looking at patients in our department who presented with hip fractures and matched patients based on age, race, comorbidities, and level of trauma with patients who have received a femoral nerve block and those that didn't. And so far, what our data showed is that compared with patients who didn't receive femoral nerve blocks, the patients who did receive substantially less opioids. And this was statistically significant, both when analyzed using a paired t-test, as well as the Mann-Whitney U-test, which assumed a non-normal distribution given our small sample size. Now, our current study has multiple limitations. So small sample being the biggest one of them. And then second, given that it's a retrospective cohort study, we're not able to randomize our patient population. So where are we going in the future? We intend to do a prospective investigation. So we want to do a randomized controlled trial looking at femoral nerve block utilization in the ED in patients greater than 65 who present in our department with a hip fracture. We'll train a team to perform femoral nerve blocks and then assess their level of pain on a 10-point scale, and then also look at milligram morphine equivalents of opioid use. So what have we done until this point? We have so far evaluated the use of femoral nerve blocks in our emergency department. Now we're coordinating with our department to get faculty buy-in in order to assemble a femoral nerve block team. And finally, we're going to conduct a prospective randomized controlled trial in order to assess the utilization of opioids in patients who received and didn't receive a femoral nerve block for their hip fracture. Thank you for listening, and I'm happy to take any questions you might have.
Hi, my name is Alexis Salerno. I'm an assistant professor at the University of Maryland School of Medicine, and I am the Emergency Ultrasound Fellowship Director. I'm excited today to share a little bit about our project, Quantitative Analysis of Emergency Physician Performed Biparietal Diameter Estimate for Gestational Age. My co-authors and I do not have any financial disclosures, and this study was not funded. In the emergency department, when we are taking care of an acutely ill pregnant patient, it's really important to be able to estimate the fetal gestational age. Ultrasound has been shown to be a reproducible and accurate measurement of estimating fetal gestational age. It's much better than asking your patient what her LMP is. Using ultrasound, there are many ways to estimate fetal gestational age, including gestational sac, ground rump length, biparietal diameter, and femur length. The biparietal diameter is measured in the transverse section of the fetal head at the level of the thalami. It should be measured at the parietal bone with the cursor from the outer portion of the anterior wall to the inner portion of the posterior wall. After looking at a few QA studies, I found that this is the most difficult to measure correctly. In fact, if you look at the image on the right, I believe the caliper is highlighted in blue or a little bit low, and it should be moved up to where the red arrow is. And this got us thinking, if we're not able to correctly perform this measurement, is this affecting our accuracy? So the objectives of this study were to identify the quantitative accuracy of emergency physician performed biparietal diameter estimates for gestational age as compared to the standard radiological or OB ultrasound estimates. We hypothesized that most of the emergency physician gestational age estimates would be within 14 days of that standard radiological or OB estimate. We performed the chart review of our academic emergency department ultrasound database, which was QPath, and our electronic medical record for cases where a BPD measurement was performed by an emergency physician. We excluded duplicate images if we were unable to identify a medical record, so most of these were simulation cases. If they were not performed by an EP, not performed at a primary hospital, performed in pediatric patients, or we could not find a radiological or OB study within 60 days. We then recorded the ED gestational age estimate in days, the standard estimate of gestational age in days, and then calculated the difference. So we did standard gestational age in days minus the ED gestational age in days, and then took the date change from the ED study. The data was then analyzed using a normal binomial approximation. We looked from January 2016, which is when our QPath database started, to September 2020 and found about 2,000 studies. After looking at all the different exclusion criteria, we found 74 that could be included. Our results showed that there was a large proportion of studies within 14 days, but there was still a large majority under 7 and 6 days. And this is the graphical presentation of our data, which shows good correlation between the EP and standard gestational age. And this is the Bland-Altman representation of our data. So in conclusion, the study shows that EP performed BPD measurement for gestational age is quantitatively accurate with 91% of estimates within 14 days of the standard radiological or obstetrical estimate. I'd like to thank my co-authors as well as the University of Maryland for their continued support. Thank you very much.
Good afternoon. My name is Dr. Elliot Chin, and I'm a research fellow at Hennepin County Medical Center in Minneapolis, Minnesota. Today, I will be presenting feasibility of fully incorporating transesophageal echocardiography into an emergency medicine practice. As emergency medicine physicians, we are trained to use ultrasound, including transthoracic echocardiography during cardiac arrest. TTE in cardiac arrest can be problematic. For example, air in the chest can obscure images, compressions block access to our views, and using TTE for pulse checks has been shown to prolong pauses in chest compressions. All three issues can be resolved with the use of transesophageal echocardiography. Blavis et al. Described the first use of TE in the ED in 2008 with the case series, and since then, we've seen additional case series and studies showing it decreases pauses in chest compressions, and it identifies reversible pathology not seen with TTE, cardiac monitoring, or physical exam. However, the majority of those performing ultrasounds in these studies have some sort of advanced ultrasound training and likely make up a minority of groups in that ED, thus limiting their generalizability and creating a significant knowledge gap. TE was first used at Hennepin County Medical Center in 2014, initially limited to ultrasound faculty. Pleased with the ability to obtain superior views and access to continuous visualization of the heart, it was decided by our chair that we would have mandatory training and credentialing of all faculty to use TEE, or more specifically, focused transesophageal echocardiography, as we are only obtaining up to 4 views and limit its use to cardiac arrest and undifferentiated hypotension. Performing TEs on live patients was not required to be credentialed. One of the requirements from our institution was creating and maintaining a quality improvement database. Within it, we would keep track of who did each FTE and whether or not there were any complications. So with that, the goal of this presentation is to describe our experience with FTE over a 42-month period after our entire department was credentialed, specifically the following. What percentage of times were our faculty able to obtain TEE images? What was the quality like? How did TEE images compare to TTE images? Were there any evidence of adverse outcomes? And most importantly, were there any differences between those with and without advanced ultrasound training? The data for this presentation comes from the QID, which was updated during weekly ultrasound faculty meetings, where they would review all TE images and rate them as either good, fair, or poor. If TTE images were saved, they were compared to FTE images. For descriptions of use, outcomes, and safety information, we had 3 trained abstractors review each case. We took a 10% random sample of all cases to calculate inter-rater reliability. Here is a table to answer our initial questions. First and foremost, I want to point out that over this 42-month period, we performed 557 FTEs. This is at least 10 times the amount of patients in the majority of other ED articles on TE in the ED. In 99% of cases, our faculty were able to obtain images. Here, there is no difference between those with and without advanced ultrasound training. TE images were interpretable in 99% of those with advanced ultrasound training, by adding those two together, and 94% add those two together in those without advanced ultrasound training. While there was a significant difference between these groups, I want to stress that 94% of the time, non-experts were able to obtain images which were able to answer their clinical question. When TT images were available for comparison, TE images were superior the majority amount of the time, with a slight but significant difference between those with and without advanced ultrasound training. All 52 faculty have performed at least 1 FTE during this 42-month period. The median number of scans was 10, as marked by this line here. 75% of FTEs were performed by non-ultrasound experts, increasing the generalizability of our findings. When were we using FTE? The majority of the time it was in cardiac arrest or the peri-arrest state. Peri-arrest meaning the patient survived long enough to have post-ROSC monitoring. Additionally, we did not limit our use to cardiac arrest, as indicated by the 68 patients whose indication was shock. During the case, our faculty used FTE before ROSC, after ROSC, and most often during active CPR. In 97% of cases, TE was in place before a patient rearrested or received a shock, suggesting its ability to identify impending rearrest. You can also see that the TE probe was in place during a shock in over 100 cases. 36% of cardiac arrest cases survived a hospital admission, 70% survived a hospital discharge, and 75% of those in shock survived a hospital discharge. Out of all 557 cases, we were able to identify one major complication, a dislodged endotracheal tube, which was identified and followed by immediate reintubation before any desaturation occurred. There were no known cases of esophageal perforation. There are several limitations. First, this was done retrospectively and thus prone to potential bias. We relied on the EMR and QID for all of our data. While our abstractors were not blinded, the kappa for all important variables ranged from 0.6 to 1. Faculty reviewing TEs were not blinded to the images they were reviewing. In conclusion, I want to convey that it is possible to implement faculty-wide credentialing of TEE as illustrated by our ability to obtain images in 99% of cases. While ultrasound faculty were able to obtain better images and superior images to TTE, over 90% of the time, non-experts were able to obtain clinically useful images which were better than TTE. Thank you for your time.
Hello, my name is Campbell Bilal Haley. I'm a fourth-year medical student at Tufts University. And today I'll be presenting my research growth and globalization of point-of-care ultrasound scholarship in emergency medicine. I have no disclosures. For background, I started looking at this study because of how rapidly POCUS has grown in the last 20 years in terms of scope and educational opportunities. There were fewer than 50 fellows in 2009, and there were 197 in 2020. So my expectation was that this coincided with a substantial increase in the research being done. Previous studies have looked at abstracts submitted to SAEM as a proxy for the growth of the field in 2018, but no previous review of published EM POCUS studies has been done. So that's what we were trying to accomplish with this study. For our methods, our first step was to do a scoping search of POCUS literature to identify keywords and determine the total breadth of POCUS literature across all subspecialties, which resulted in 4,300 results. Through this search, we identified key journals. We also had an expert in the field identify other journals in EM POCUS that frequently published. And this search yielded 1,600 results, which were screened for inclusion or exclusion based on the two main characteristics of having EM authorship and being relevant to point of care ultrasound specifically. So our total included records were 1,330 over this 20-year period. We excluded 321. Our findings in the study, we saw a rapid growth of publications beginning in the early 2000s. As you can see from this graph, the 5-year average in the early 2000s and 2000 and 2004 was only 8.8 publications per year. And then between 2015 and 2019, this grew substantially to 134.8. In each 5-year period, it at least doubled. And you can just see the dramatic rise in the amount of publications that have been made in the last 20 years from this graph. We also wanted to look at where EM POCUS studies come from. Not surprisingly, in the early 2000s, the United States dominated publication of EM POCUS. There were 89% of all studies that we found in 2004 were from the United States, but this steadily decreased, and in the previous 5 years before 2020, only 64% of all studies in EM POCUS were from the United States. This is due to a rapid growth in this subspecialty in Canada and in Asia. We saw a lot of studies just through qualitative analysis that came from Turkey. So it's clear there's a lot of work that's being done in different countries in EM POCUS from our study. We also looked at the publication types organized based on a pyramid of evidence types. We separated it into 5 categories: case-based literature, observational studies, reviews, editorials and opinion, and randomized controlled trials. We found in our study that case-based literature, observational studies, and surveys were by far the most common studies, accounting for about 75% of all of the studies that we looked at. RCTs were pretty stable at about 3% of all studies, but due to the increase in total studies, it's clear that there are more RCTs being done in general. So as far as our findings, we found that there was significant growth in total publications and international publications between 2000 and 2020, as evidenced by the proportional decrease in total US studies in that time. We also found that there were no major changes in proportions of publication type. The majority of EM-POCUS studies are still case-based or observational studies. So what does this mean? What context does this provide? I think importantly, it shows that we have significant room for improvement in our multi-center collaboration in EM-POCUS. How can we expand the amount of studies that are done across institutions to build the evidence base for this subspecialty? I think is an important question that this study raises. And then also, is there a role for more high quality studies in EM-POCUS, more RCTs that give a clear intervention and control group? But overall, this study encapsulates what is a dramatic rise in EM-POCUS literature in the last 20 years. And we found some really interesting results as a result of this review. Thank you for your time. Thank you to SAEM, and I hope you all enjoy the rest of this conference. Here are my references.
Hello everyone, my name is Mariam Fofana, and I'm a second-year resident at Stanford Emergency Medicine. My presentation today is ultrasound-guided serratus anterior plain block improves pain and may improve inspiratory volume in patients with multiple rib fractures. The authors of the study are below, including myself, Dr. Victor Sadaskis, Dalton Brunson, Dr. James Quinn, and Dr. Yo-Yo Danmu. This study was funded by a SAEM Foundation grant through the Academy of Emergency Ultrasound. Rib fractures are commonly seen in patients who present to the emergency department with chest wall trauma. The mainstay of treatment of rib fractures is pain control. Controlling pain is essential in avoiding complications associated with rib fractures such as pneumonia or respiratory failure. Regional anesthesia has been proposed for pain control due to a superior side effect profile compared to systemic analgesia. Our objective is to evaluate the effect of emergency physician performed ultrasound-guided serratus anterior plain block on pain and respiratory function in ED patients with multiple acute rib fractures. Our study is a prospective observational cohort study with inclusion criteria of adult ED patients with 2 or more anterior or lateral rib fractures, trauma that has occurred within the last 24 hours, and ED presentation between 7 a.m. and 11 p.m. for screening purposes. Our exclusion criteria is stated on the slide, some of which are posterior rib fractures and bilateral rib fractures. Whether or not eligible patients receive the serratus anterior plain block depended on whether a trained emergency medicine resident or attending was in-house to perform the procedure. The primary outcomes are change in pain score and interferometry volume from the time of diagnosis of the fractures to 3 hours afterwards. Secondary outcomes are amount of analgesia provided in the ED and within the first 24 hours of hospital stay, length of hospital stay, need for supplementation of oxygen, and new diagnosis of pneumonia during admission. Our data today is based off of the primary outcomes. We're also collecting the secondary outcomes, although the data analysis of that portion is still pending. I'm going to briefly describe how the serratus anterior plain block is conducted. The image on the left is an example of how the patient is positioned while performing in-plane needle guidance. The image on the right is an ultrasound view of the landmarks. In this image, the top yellow landmark is the fascial plane above the serratus muscle, and the bottom yellow line is the rib. The serratus anterior muscle is between the 2 yellow lines. To perform the block, an injection of 0.5 cc per kilograms of 0.25% of bupivacaine is injected above the serratus anterior muscle, basically above the top yellow line. For our results, 23 patients were enrolled, with 11 being part of the intervention group and 12 in the control group. The mean age of our patients is 65, with 54% being men and 46% women. Here is a bar graph showing the change in pain scores between the serratus anterior plane block group, labeled as SAPB, and the control group. For the SAPB group, the mean pain score decreased from 8.5 to 4.5. For the control group, the mean pain score decreased from 6.3 to 5. With the use of t-tests, the change between the two groups were found to be significant with a p-value of 0.008. Here is a bar graph showing the change in incidence spirometry volume between the SAPB group and the control group. For the SAPB group, the mean incidence spirometry volume increased from 1,464 milliliters to 1,655 milliliters. For the control group, the mean decreased from 1,495 milliliters to 1,413 milliliters. With the use of t-tests, the change between the two groups were found to be nearly significant, but not quite, with a p-value of 0.078. Currently, enrollment is ongoing. Hopefully, we have a large enough sample size to assess for statistical significance at the end of study enrollment. In conclusion, the serratus anterior plane block caused a significant reduction in pain and a trend towards improving expiratory volume compared to standard analgesia alone. Thank you for listening to my presentation. Please feel free to reach out. My email is mfofana@stanford.edu, and my name on Twitter is @drmariamfo.
Hi, my name is Yo-Yo Dwamu, and on behalf of myself and my co-authors from Stanford University and the UCSF Department of Emergency Medicine, I'm presenting an abstract on the point-of-care lung ultrasound findings associated with need for intensive care in COVID-positive patients. We have no relevant financial disclosures. Point-of-care lung ultrasound has been utilized for multiple pulmonary disorders, including bacterial pneumonia and interstitial lung disease. Lung ultrasound was adapted for the assessment of COVID-19 patients pretty early in the emergence of this disease, both in the US and internationally. Advantages of lung ultrasound include the ability to perform serial exams, the ability to obtain clinical data at the bedside without the need to transport patients, and its relative ease of decontamination compared to other radiology modalities. The objective of this study was to evaluate the prognostic potential of findings on initial point-of-care lung ultrasound performed either in the emergency department or upon hospital admission on the need for intensive care in patients who tested positive for COVID-19. This was a prospective, multi-center observational study that took place across several academic and community sites in the Bay Area of California. A group of emergency medicine and internal medicine physicians who had prior ultrasound training performed standardized lung ultrasounds on patients suspected of having COVID-19. These screening scans took place either in the emergency department or on the inpatient floor if patients were admitted, and they were all done within 24 hours of ED arrival. For inclusion in the study, we took patients who were over 18 years old and patients who eventually did test positive for COVID-19. Lung ultrasound was performed using a 12-zone protocol. Each scan was saved and then reviewed independently by 2 investigators. If there was any discrepancy, the investigators had a conversation and came to a consensus about the findings. The lung ultrasound findings that we were looking at and using as predictors for our outcome were A lines, B lines, subpleural consolidations, and pleural effusions. The primary outcome was the need for ICU admission during that hospital visit. On the left is a diagram showing the 12-zone lung protocol that we used. It involves 4 anterior and 2 posterior zones per side of the chest. On the right is a lung ultrasound showing A lines, which is a finding in normal lung. A lines are the hyperechoic linear structures parallel with the pleural line. On this slide, we see 2 abnormal lung ultrasound findings that have been associated with COVID-19. On the left are B lines, a hyperechoic structure that projects perpendicularly from the pleural line all the way down to the bottom of the ultrasound field. This can be associated with fluid on the lung or infection. On the right is a subpleural consolidation, the heterogeneous structure just underneath the pleural line that is usually associated with a lung infection. 94 COVID-positive patients were enrolled in total. Of those, 21 were eventually admitted to the ICU. We found that patients who would require ICU admission had abnormal initial lung ultrasounds. None of them had A lines in most of their lung zones on their ultrasound that was done in the emergency department or within 24 hours of ED arrival. Patients who were admitted to the ICU were also more likely to have anterior or lateral subpleural consolidations on these initial lung ultrasounds compared to those who did not require ICU level of care. This table shows some of the other ultrasound findings that were not statistically significantly different between those patients who did and did not require ICU level of care. For example, bilateral B-lines and posterior consolidation was seen in many patients who tested positive for COVID-19. It's thought that bilateral B-lines are similar to the bilateral ground glass opacities that are often seen on chest CT for COVID-positive patients. So in summary, we found that COVID-19 patients who later required ICU admission had abnormal initial lung ultrasound findings in over half of their lung fields. We also found that anterior and lateral subpleural consolidations were more associated with the need for ICU admission than posterior consolidations. We hope that identifying predictors of more severe courses of COVID may help with the disposition decisions for these patients when they present to the emergency department. Thank you for your time and for your attention. Please feel free to reach out by email or on Twitter for any questions you may have, to collaborate, or just to say hello.
Good morning, my name is Tingshi Tan. I am a current ultrasound fellow at Stanford University, and this was a project that I started in residency at Yale, entitled Prototype Development of a 3D Printed Ultrasound Guided IV Catheter Phantom. I have no disclosures.
So ultrasound-guided peripheral vascular access is an important procedure for EM physicians to master. Approximately 35% of ED patients have difficult peripheral access, and ultrasound guidance has been shown to increase the likelihood of successful cannulation in these patients. With regards to training residents on ultrasound IV access, most institutions utilize either commercial or homemade phantoms, and these have their limitations. Commercial phantoms tend to be expensive, ranging in the $400 to $600 range, and lack customizability, whereas homemade phantoms are slightly more customizable, but when made from products like gelatin or agar, tend to be single-use and degrade easily. Furthermore, these phantoms are typically made into blocks with vessels and can lack the realism of an upper arm. So the objectives of our project was to develop a low-cost reusable model whose components are customizable. We wanted to see if we could utilize 3D printing in order to achieve this, since 3D printers are more readily accessible nowadays in many institutions. We wanted to compare our 3D model to a commercial model and assess the time to achieve IV placement in these two models, as well as the perceived realism of our 3D printed model compared to commercial models. In terms of model development, we utilized stereolithography, or SLA, in order to 3D print our moles. And you filled the upper arm base with silicone, and the inner arm was made of ballistic gel. The lower right-hand portion shows an example of what one of our 3D printed vessels look like, and these structures are removed from the ballistic gel after the gel has solidified. So this is what our model looks like. The upper arm silicone base is in the top left-hand corner, and the top right-hand corner is what the inner arm ballistic gel piece looks like with the vessels in it. We also added a blood pressure cuff tubing in order to simulate the arteries, as well as added a silicone skin over our entire model in order to better simulate the arm.
And to the left of the screen, this is a video showing needle insertion into our model. This model is only made of ballistic gel.
We were also able to improve the echogenicity of our models in later versions, by adding either cornstarch or chalk, as well as vary the vessel sizes and bifurcation. So our initial model, the vessel diameter was about 1 centimeter, and in later ones we were able to make vessels that were about 0.5 centimeter in diameter. And this is an example of what it looks like under ultrasound at the bifurcations. So in terms of total materials costs, for the entire model, it cost around $120 to produce. If you were to add additional, or if you wanted additional vessels and trajectories to be done and wanted to make another inner arm model, it would cost about $20 worth of ballistic gel to make, and the 3D printed vessels would cost about $5 worth of resin. In terms of prototype testing, we recruited 8 EM attendings as well as 13 EM residents. All our participants have had prior experiences in placing ultrasound-guided IVs in patients. We found no significant differences in mean time for ultrasound IV placement in our 3D model versus commercial model, and we did note a trend towards a higher mean realism score for our 3D model.
In terms of limitations for the study, this was a single-center study with a small sample size. It was also unclear if our time to IV placement should be faster or slower in a better simulation model. With regards to model limitations, track marks do become visible after multiple attempts, typically more than 20, and our ability to vary the trajectory and bifurcation of the vessels are limited by the ability to remove the inner vessel mold.
So in conclusion, we developed a 3D printed ultrasound IV model that is more economical than the commercial Phantom. It does not sacrifice time required for IV placement or realism. Future steps will be to assess clinical utility in medical education. Please feel free to reach out to my email below if you have any additional questions or want to collaborate. And I'm happy to take questions now, and thank you for your time.
My name is Christopher Thom from the University of Virginia, and our study was titled The Utility of Routine Transvaginal Ultrasound After Intrauterine Pregnancy Identification on Abdominal Ultrasound. Myself, as well as my co-authors, have no financial conflicts of interest to disclose. Some background information, we know that both transabdominal and transvaginal ultrasound can both be utilized in the evaluation of ED patients with early pregnancy complaints. Transvaginal ultrasound does provide superior imaging quality, both from a higher frequency standpoint as well as from a probe position standpoint, but it does add cost, time, potential patient discomfort, and a lot of complexity that I'm sure a lot of you are aware of related to the high-level disinfection process that's necessary with transvaginal ultrasound, but is not with transabdominal ultrasound. Specialty societies do not always provide clear guidance on the necessity of transvaginal ultrasound and adnexa visualization in early pregnancy evaluation. And there is actually a dearth of direct evidence supporting or refuting the usefulness of routine transvaginal ultrasound following IUP identification on transabdominal ultrasound. And so our objectives here were to determine the added value, if there is added value, and what is that added value, of pursuing a transvaginal ultrasound in cases where an IUP has been definitively identified already on transabdominal ultrasound. I think most of us in emergency medicine operate on the sort of IUP and you're done philosophy, except perhaps specific circumstances like fertility treatments. This strategy eliminates the need for transvaginal ultrasound, except in those cases where the finding of an IUP is not clear. However, it's not entirely clear that every specialty operates on the same paradigm, and there's also a dearth of strong evidence to guide that practice. Therefore, we sort of sought to quantify what that added value is or to look into it further. Our study was a prospective study of previously archived radiology department first trimester ultrasounds in ED patients. We had 2 ED physicians with specialized ultrasound training who reviewed only the transabdominal images from these studies and were blinded to all of their information, including the transvaginal images. Their findings were then compared to the radiologist interpretation, which was inclusive of the entire study. This was the form that our ED physicians used. They would note whether there was an IUP, and then they would note secondary findings as listed below. Our allocation diagram is shown here. We had 108 studies total that were included. Importantly, there were only 2 patients in 2 studies where a transabdominal ultrasound was performed and no transvaginal ultrasound was performed. In other words, the vast majority of these patients, both a transabdominal and a transvaginal ultrasound was done in the Department of Radiology, regardless of what was found on that transabdominal ultrasound. When we looked back through the electronic medical record, those 2 patients had both specified, the 2 patients that just got a transabdominal ultrasound had both specified that they didn't want or declined the transvaginal ultrasound. So we had 108 studies that met inclusion criteria. Amongst these, 82 had intrauterine pregnancies identified on the radiologist report. The sensitivity of the ED physicians on their transabdominal ultrasound review of those studies was 77%. The specificity was 98%. There was 1 false positive amongst the 2 ED physician review of all the studies. So 1 case where the ED physician thought there was an IUP where there was not. The top left here shows us the radiologist interpretation of pregnancy location overall. The bottom right here shows us a 2x2 diagram that's pooled for the EP or emergency physician review of transabdominal ultrasound images as compared to the radiologist report. And we can see sensitivity, specificity, accuracy, and our correlation coefficient was high for IUP identification between our 2 ED physician reviewers. Other results we looked at, so subchorionic hemorrhage is shown here. Sensitivity is much lower, and we'll talk about that. Fetal demise on the bottom left, our ED physicians identified all of those correctly. And then on the bottom right, ovarian cyst, how we handled this was we basically used significant ovarian cyst, whether that was present or absent, was determined by whether or not the radiologist had put it in their impression section of their report. So if it showed up in the impression section, then we counted it as potentially a significant ovarian cyst, and our reviewers were asked to look for those as they were looking through the transabdominal ultrasound images. And so the specificity of IUP identification on ED physician review of transabdominal ultrasound was very high at 98%. There were 2 ectopic pregnancies in our cohort, neither of which were mistaken for IUP on transabdominal ultrasound review by either ED physician. Each case of fetal demise was detected. Subchorionic hemorrhage was frequently missed on transabdominal ultrasound review. Significant ovarian cysts were rare in this study cohort. There were 3 that were noted in the radiologist impression section of the report. While our detection was low for those, none of these required intervention. And so transabdominal ultrasound identification of IUP is highly specific as compared to transvaginal ultrasound. While subchorionic hemorrhage is often missed on transabdominal ultrasound, the clinical significance of identifying each one of those is questionable. There's no direct management that is done, and often those are observation or conservative management, so identifying each one is perhaps not entirely critical. And then no significant ovarian cyst requiring intervention was present in our cohort. And so following the identification of an IUP on transabdominal ultrasound, it appears the added diagnostic value of performing routine transvaginal ultrasound on ED patients when in first trimester pregnancy is low. Given that there is added time and cost of transvaginal ultrasound, selective instead of routine usage should be employed.
Hello, my name is Leela Posa, and I'm the Emergency Ultrasound Director at Jackson Memorial Hospital in Miami, Florida. My presentation today is called Challenges in Quality Training of Emergency Ultrasound at Florida Emergency Medicine Residency Programs, a pilot study. My wonderful research team is comprised of Kerry O'Sullivan, Andrew DeZenzo, and Nisha Puri from the University of Miami Miller School of Medicine, Dr. David Kines from the Mount Sinai Medical Center, Miami, and myself. This project was conceived due to a training shortfall at my program. My first-year residents have a brief ultrasound orientation at the start of their academic year. However, the bulk of the training is done on mandatory 2-week ultrasound rotations. Thus, residents whose rotations are scheduled late in the academic year are at a significant disadvantage. Senior residents suffer from the perceived lack of an easily accessible quality reference. This prompted me to explore the extent of this problem and possible solutions. A simplified conceptual framework involves 3 essential components to quality training: guidelines, the EUS director trainers, and the EM resident trainees. Our larger project evaluates all three components and their interaction. However, my presentation today is on the trainer component. As a brief introduction, minimal imaging criteria is a set of standards required for emergency ultrasound scans to be considered technically proficient. These criteria are not standard across residency programs and are most often individually curated by emergency ultrasound directors. The American College of Emergency Physicians published an imaging compendium in 2006, revised in 2014. This is probably the most widely used resource and reference for minimal imaging criteria. Our overall project goal is to improve efficacy of EUS quality training by understanding the dynamics of the training process. At the trainee level, we are interested in resident attitudes, confidence, and knowledge of minimal imaging criteria, as well as resident learning preferences. At the trainer level, we are interested in emergency ultrasound director attitudes to minimal imaging criteria, as well as current methods for technical proficiency training. In 2020, we reached out to EUS directors at all 19 EM residency programs in Florida. We distributed a 10-item electronic survey that assessed demographics, methods of training, assessment of image acquisition, utilization of standard MIC, and resident access to program standards. Data were analyzed with descriptive statistics. Of 19 programs, 10 agreed to participate in our study for a response rate of 53%. 80% of directors agreed that MIC improved the quality of ultrasound image acquisition by trainees, and 70% used a defined set of MIC at their program. Of all methods, 100% of directors cited in-person image review as the most effective way to optimize image acquisition by residents. 60% of EUS directors believed that archived image review, and 40% of directors believed that standardization of MIC are also effective. At the 7 surveyed programs that utilized MIC, 70% of EUS directors based their criteria on the ASAP imaging compendium, 60% on personal training and experience, 40% on lectures, and 10% on research. EUS directors taught MIC mostly with lectures, clinical demonstrations, and websites. 40% taught with required reading, and fewer than 20% utilized ebooks and textbooks. 60% of EUS directors stated that their residents referenced MIC on a PDF, 30% through memory, 30% on a website, and 30% in the ASAP imaging compendium. Our small pilot study suggests important implications for the field of EUS. There is a wide variation in technical proficiency training, which might need standardization. The majority of surveyed Florida EUS directors have indicated a strong interest in developing a shared, standardized method for training. A larger survey of EM residency programs might demonstrate similar training deficiencies and shared interest for optimization of quality training. Very quickly, let's sneak peek at the rest of our project. We surveyed 186 EM residents at 6 EM programs. 112 residents responded, and we found that the majority of residents believe that MIC is important for training and quality assurance. However, their reported knowledge and confidence in MIC is low. For initial learning, more than half of the residents preferred lectures, mobile applications, and websites. Only 15% preferred textbooks. For reference, more than half preferred a mobile application or a pocket guide, almost double the preference for a website or handout. Our team is in the process of developing a free and easily accessible mobile application for quick and easy MIC reference. You too can get this app by clicking on the displayed QR codes. My last slide are my references.
Hi, my name is Tingshi Tan, and I am a current ultrasound fellow at Stanford University. This was a project that I started in residency at Yale. titled Emergency Department Echocardiographic Findings Associated with Subsequent Coronary Intervention. I have no disclosures. In terms of background, chest pain is the second most common ED chief complaint with 7.6 million visits annually. Of the 1.1 million hospitalized annually for acute coronary syndrome, 70% are due to unstable angina or non-ST elevation myocardial infarction or NSTEMI. The AHA recommends early invasive strategies in patients with elevated risk who do not meet STEMI criteria. However, risk stratification of this group of patients remains a challenge in the emergency department. One approach to help with risk stratification is the detection of regional wall motion abnormalities, or RWMA. The reason for looking at this modality is that the presence of RWMA have been associated with significant coronary artery disease and can appear earlier than ECG changes. Furthermore, emergency physicians can be trained to detect focal or regional wall motion abnormalities on echo. The objective of our study is to investigate whether emergency physician performed point-of-care echo or EP echo could help identify patients not meeting STEMI criteria who would benefit from coronary intervention, such as percutaneous coronary intervention or PCI, or referral to coronary artery bypass grafting or CABG. In terms of methods, this was a retrospective study looking at EDs in two areas, so a suburban freestanding emergency department as well as an urban academic ED. Patients were included if they were over 18, received an EP echo, and underwent coronary angiography within 72 hours of ED presentations. Patients were excluded if they had STEMI on ECG at any point during their ED stay. Our EP echoes were read by 2 ultrasound fellowship trained emergency physicians and graded according to whether or not RWMA was definitely present, definitely absent, probably absent, or uninterpretable. To reach our current cohort of patients, we sequentially reviewed patients who went to cath lab within 72 hours and had an EP echo done, and excluded any patients who had an isolated right heart cath or pericardiocentesis in the cath lab. Also excluded any patients who met STEMI criteria at any point in ED to reach a population of 225. We ended up excluding one patient since the original ultrasound clips could not be located to reach our final population of 224. This is a breakdown of our demographics. We had 122 patients in the no coronary intervention group and 102 in the coronary intervention group. We also noted age and sex to be statistically significant between our two groups, with older males more likely to undergo coronary intervention. So for the rest of our results, in our included patients who received a coronary intervention, the presence of RWMA was 30% sensitive and 73% specific. In patients with definite RWMA, sensitivity was slightly lower at 17%, but had a higher specificity of 86%. This study is limited in that it was a single-center retrospective study that only included patients undergoing coronary angiography. The other limitation we had was that our weighted kappa was fair, and this could be for several reasons. One, that the interpretation of regional wall motion abnormalities in patients with global cardiomyopathy was challenging, and the second being that the images acquired may not have been optimized for regional wall motion abnormality detection. So in conclusion, the presence of definite wall motion abnormalities in EP echo was relatively specific, and this may identify patients without evidence of STEMI on EKG who are likely to require or benefit from intervention. Further studies will include a prospective evaluation of RWMA on EP echoes in this population. Thank you so much for your time, and I'm happy to take questions.
Good afternoon, everyone, and thank you to SAEM for the opportunity to present our research study today. My name is Sarah Frazier, and I am an assistant professor of emergency medicine at George Washington University. We performed a retrospective cohort study to examine FAST exam errors in our emergency department over 6 years. Our authors report no conflicts of interest and receive no financial support to conduct this research study. Many trauma patients undergo FAST imaging in the emergency department to diagnose internal bleeding and identify patients who need operative management. Hemodynamically stable patients whose ultrasound reveals concern for internal bleeding undergo CT imaging to determine whether operative management is necessary. George Washington is an urban academic level 1 trauma center with many FAST exams performed throughout the year. We use QPath to store ultrasound images, document interpretations, and provide feedback to clinician sonographers. The ultrasound faculty complete a QA worksheet and identify studies as true positive, true negative, false negative, technically limited, undocumented, or incomplete. The ultrasound faculty review 100% of the QA worksheets. The majority of residents performing the FAST exam in our trauma bays are in their 2nd or 3rd year of training. Common reasons for false negative scans in the literature include clotted blood, which is hyperechoic, or a very small amount of blood that the sonographer misses. Other reasons for false negative scans include missing critical areas such as the inferior edge of the liver or failing to use adequate depth for pelvis images. Common reasons for false positive scans in the literature include physiologic free fluid, which is often found in young adults, loops of bowel, perinephric or pericardial fat, and the presence of free fluid in older patients due to medical illness such as ascites. We performed an observational retrospective cohort study of adult trauma activation patients seen at GW over the course of 6 years. FAST exams that were identified as false positive or false negative exams when compared with CT imaging and QPath were included for analysis. Of the 4,860 FAST exams that were documented in QPath over 6 years, we initially identified 27 false positive and 75 false negative FAST exams. The sensitivity was 70.6% and the specificity was 99.1%. Overall, a shocking 29.8% of the FAST exams were undocumented, technically limited, or missing images, making an interpretation by the ultrasound attending reviewer impossible. There were a total of 27 false positive FAST exams, 12 of which also had a CT scan performed, which could be utilized as a reference standard. 8 charts were excluded because the results of the FAST exam had been correctly interpreted contemporaneously on real-time trauma room flowsheet documentation, yet incorrectly reported in QPath by the resident. None of the 12 patients with false positive FAST exams underwent any procedures based on the sonographic findings prior to CT imaging. There were 75 false negative FAST scans, 42 of which had a CT scan for comparison. 11 studies were excluded because the results of the FAST exam had been correctly interpreted in the patient's chart, yet incorrectly reported in QPath by the resident. 2 studies were excluded because there were not enough images saved for adequate interpretation by the ultrasound attending reviewer. None of the 42 patients with false negative FAST exams underwent any interventional or operative procedures prior to CT imaging. The discussion includes 2 components, one of which examines the reason behind false positive and false negative ultrasound images, and the second part involves the fact that nearly 30% of our trauma FAST exams were either entirely undocumented or technically limited. False positive and false negative scans occur with some frequency, but sensitivity and specificity of documented FAST exams with CT as the reference standard was similar to prior studies. Our gold standard was CT, not OR, which is worth noting and likely resulted in a sicker cohort of patients since many patients only had a FAST exam but no other imaging as they were deemed stable or had low concern for thoracic or abdominal trauma based on mechanism. RPGY2 residents performed the bulk of these exams as they are assigned to the trauma patients. We plan to put together a FAST pitfalls lecture with bedside scanning before interns start their 2nd year of residency to reiterate the causes of false positive and false negative scans and discuss how to troubleshoot when faced with poor imaging windows. In terms of future research ideas, it would be interesting to study if residents who had lower overall scanning numbers in QPath were also more likely to either have false positive or false negative scans or even undocumented scans. It would also be interesting to see if the false positive and false negative scans occurred at the beginning of the 2nd year as opposed to the end of the 2nd PGY year. Perhaps most concerning, however, is the fact that nearly 30% of our FAST exams were either undocumented or technically limited. We plan to look at whether most of the undocumented studies occurred early in the changeover to QPATH, or whether the percent of undocumented studies is fairly constant from year to year. We also plan to look at whether there is a correlation between the time of day or night, weekends, or even shift duration, 8 hours versus 12-hour shifts for the residents, on the number of undocumented or TLS studies in QPATH. I would like to thank Kiana Kosrabian, my research assistant, and a current second-year George Washington medical student for her help, and my fellow emergency medicine colleagues at George Washington for their assistance with the study. Thank you very much.